So, Dr. Scholz, we have many questions regarding relapse therapy from our YouTube comment section, and I thought today we would answer some of them. So, can you characterize what are the factors that would determine that prostate cancer has relapsed?
Usually a rising PSA. The problem with that is that you can have rising PSA in men who have not relapsed. So a distinction has to be made. In the old days, we had to let the PSA rise above a certain threshold, to say like 2 points above the nadir, with nadir being the lowest PSA that's attained after therapy. So whether you have surgery or radiation, the PSA goes down to a lowest point, that's called the nadir. And then if the PSA started rising 2 whole points above that for radiation patients, that was called a relapse. Wasn't always the case, because you can have PSA bumps where people get delayed radiation prostatitis, and the PSA can rise more than 2 points and then settle back down on its own. That's not cancer. That's inflammation in the residual prostate after radiation. I think one thing to comment on about relapse disease is in the prostate cancer realm, it's quite different from other cancers. The patients who have relapse disease after treatment for prostate cancer, and of course you have to have been in a remission to be relapsed. We're not talking about people that embark with really bad cancers and they can never get into a remission. But people that have gone into a remission and then relapse and develop a rising PSA that is indeed from cancer, the remarkable thing about prostate cancer is that you have a good chance to try and cure the relapse. Most other cancers, if you think of lung and pancreas and whatnot, if they relapse, the vast majority are incurable. And this is one of the components of that dreadful word cancer that creates all kinds of fear and consternation. People know intuitively that you've got one chance the first time you treat it to cure it. And if you don't cure it, you could go on and die from it. So there are many reasons that prostate cancer is not as dangerous and deadly as other cancers. Better treatments, better monitoring tools, but the fact that you get another chance to cure it, even if it relapses, is a remarkably good aspect of prostate cancer, to get a second try, and in some cases even a third try if the second attempt fails.
So, I mean, you've seen thousands of prostate cancer patients over your career. How many have you seen have a remission, get a relapse disease, and then actually come to cure? Is there a certain percentage that you would see? Is it rather high?
Many have been cured. There are different types of relapses, and of course this is getting defined with greater precision now that we have these new PSMA PET scans. So the location of the relapse is very important. The type of cancer that was treated initially is important. If someone already had lymph node disease when they had their initial therapy, if they have a relapse, their chances for cure are not going to be as good as someone that had disease that was only in the prostate gland and remains in the prostate gland. So the type of relapse is important in terms of predicting whether someone is likely to be cured. The good news, of course, is that even in the men that are not cured, the relapses can be controlled probably for an average of about 15 to 18 years with modern state-of-the-art hormone therapy. So it's not super desirable to be on hormone therapy. It has a number of side effects that aren't that pleasant, but it is very effective in keeping the disease in check for many, many years.
So you've used 2 different terms here, cured and remission. Can you explain the differences to people? Because I think that if somebody came out of remission, relapsed, and then was cured, would they consider that back in remission, or what's the definition of cured at that point?
Right. So the idea of remission, and of course there's partial remissions and complete remission. The terminology is used for all cancers, not just for prostate cancer. So a complete remission means that no detectable cancer anywhere in the body in the absence of any ongoing treatment. So it's not that they've been suppressed, but that they've been suppressed and then treatment has ceased and the disease remains undetectable. That's a complete remission. It's not a cure, because if there was a tiny speck of cancer somewhere in the body left behind that wasn't eradicated, over a period of years it can manifest by growing and become detectable, and then that's a relapse. So people that have no detectable cancer are in remission, and if they remain in remission for a specified period of time, 3 to 5 years or so, then we start talking about the likelihood that they've been cured because no relapse has occurred over a specified period of time.
So you mentioned a couple factors that would add to remission, and obviously paying attention to the type of prostate cancer, but you mentioned location. So regarding location, if the cancer is in the pelvic nodes, does that make it less likely to be able to be cured? And if so, by what percentages?
I tend to think of prostate cancer with one big divide between the patients that still have disease that appears to be confined into the prostate or the prostate area and people that have anything else. You hear a lot of talk about, maybe should I have a biopsy because it might spread the cancer? People are failing to realize that it's not the fact that the cancer got into the bloodstream because someone poked a needle at it. That the problem with metastasis occurring is that they can only occur if the cancer cells themselves have the biologic capacity to land, put down roots, and prosper in another part of the body. And that's just a different biologic type of cancer. So it's not the fact that it got out of the prostate that caused it to metastasize. It's the fact that the cancer cells were of a genre that can grow in different locations. So the presence of any cancer in a distant location is a very worrisome development. But you point out that the location itself, whether it's the lymph nodes or the bones or what part of the body are the lymph nodes located in, could have relevance into predicting whether this person is more or less curable. And yes, the patients that have lymph nodes that are close to where the prostate used to be have the best chance for being cured, even though they have early metastasis. And then as the disease spreads further and more widely, and as more and more spots appear, the chances for cure start to drop off sharply. But I have seen patients cured who've had one or two bone mets, and I've seen patients cured that have had lymph nodes that are outside the pelvis. That is less frequent. And patients that have any lymph node metastasis are not looking at high cure rates. You might say that as many as 50% of men that have a single isolated lymph node and otherwise favorable profile could be cured with salvage therapy. Salvage therapy being radiation to that lymph node, hormone treatment for 12 to 18 months with a first and second generation agent, and probably a very short course of chemotherapy, like 4 injections of a medicine called Taxotere.
So you mentioned different genres of, types of prostate cancer, ones that are more aggressive, that are going to travel and get down roots in different parts of the body. Is there a way to test for these types of genres before, maybe in the newly diagnosed setting when a patient's just coming into this space?
Well, this is the role that Gleason score has played for many years, is patients with higher Gleason scores are at greater risk for something that can spread outside the gland. And that's probably the best we have. There's genetic testing that tries to do similar type of predictive, but it's not that good. It's greatly revered and it's used a lot because it's better than nothing, but it doesn't give a lot of precision. I've had many patients with untreated Gleason 8 or 9 disease that have not developed any metastasis. And of course, we hear about the bad cases where people develop widespread metastasis with these higher Gleason scores, and sometimes even with Gleason 7s, lowish Gleason scores. It's a probabilistic construct, a prediction of risk, but it doesn't give you true clarity in an individual this will or won't spread and how far it will spread. That is usually something that is discovered over a period of time after people get treated, and you see how the situation behaves.
Thanks for watching. If you would like more information about prostate cancer, you can go ahead and subscribe to our YouTube channel. We come out with new prostate cancer videos every week. And go ahead and visit our website, PCRI.org. We have tons of information on prostate cancer that will help you.